really thank to our dear lecturers and our dear audiences, and hope to enjoy this session. Thank you.
Many thanks, dear Dr. Memar. So, dear Dr. Hamawandi, we are with you. You can share your slides.
Okay. Today's presentation will be about autism. If there is any light at the end of the tunnel, is there any hope? Really, it's a new concept, new understanding of the pathophysiology and pathogenesis of this disease. The last few decades have witnessed an alarming increase in the acquired neurological disorders among children. Acquired developmental conditions are different from genetic conditions that appear due to genetic defects. The autistic spectrum disorder are increasingly seen during the last years, namely the autistic spectrum disorders, sensory problems, developmental delays, emotional disorders, ADHD, post-concussion syndrome, tics, Tourette's, PANS, and PANDAS. Most people agree that there is no cure from autism. So they approach autistic spectrum disorders in a way that looks at the management of symptoms or development of skill and support through behavioral and educational therapy. There is a growing scientific evidence that an imbalance in the intestinal bacteria, small intestinal bacterial overgrowth, along with excessive inflammation with the brain, are probably responsible for the features associated with autism, ADHD, and other developmental disorders in the children. You know, the bacterial overgrowth means that large number of bacteria that predominantly were living in the colon, they migrate towards the small intestine and increase the number of bacteria within the small intestine up to 10,000 to 100,000 folds. This added bacterial load in the small intestine has two consequences that may contribute to autism. The first is the overproduction of propionic acid due to loss of diversity of bacterial species of the small intestine and diminished number of the healthy bacteria, allowing for colonic bacteria like Streptococcus, E. coli, Staph, Klebsiella bacteroids, Lactobacilli, and Clostridia to migrate into the small intestine where they can produce propionic acid in massive amounts. Propionic acid is a short-chain fatty acid that's normally produced in small amounts within the intestine, but higher concentrations has been linked to some of the behavioral aspects of autism. In animal studies, a high propionic acid leads to development of antisocial behaviors, increased sensitivity to sounds, light, touch, as well as gait abnormalities. In human studies, children with autism have very high concentration of propionic acid within their tissues. If the overgrowing bacteria produce propionic acid, the child will have a decreased level of awareness, poor eye contact, and may engage in strange behaviors like stimming or staring into spinning objects. The second effect is that the increased concentration of the bacteria within the small intestine causes leakage of bacterial cell wall lipopolysaccharides into the small intestinal layers that are rich in immune cells. And this triggers an inflammatory reaction referred to as a leaky gut. The leaky gut causes an increase in peripheral pro-inflammatory cytokines and allows for inflammatory priming of microglia within the central nervous system, changing them into M1 phenotype. That this phenotype fails to repair the injuries that have been done to that nervous system. The combined production of cytokines and activated microglia are mainly responsible for the developmental delays, seizures, sensory issues, and attention disorders that are associated with autism. A child is usually born with approximately 100 billion neurons. Mainly over the ensuing 5 years, it needs to be pruned. These neurons come down to 50 billions in a process referred to as synaptic pruning. In addition to the reduction in the number of functioning neurons, the networking increase. With each experience of the child, a network synaptic is accomplished, so that with a smaller number of neurons, he can accomplish larger number of tasks. Excessive inflammation from the leaky gut, microglia priming, and imbalance between omega-3 and 6 prevents the healthy microglia from pruning fast enough. That results in a developmental delay. The priming effect from the bacterial overgrowth causes many microglia, as we say, to shift into M1 phenotype, and results in the brain being less able to fully repair itself from physical, like falls, bumps, or head, emotional, fears, abuse, neglect, and inflammatory, surgery, infection, vaccine, brain injuries. So you see in this graph, you see how the normal brain, look at the blue line, how it is recovering. With every trauma, with every insult, it goes back to normal. While when we have defective pruning and defective repair of the, let's just say, damaged brain tissues, the impaired recovery result in decreased brain function, what we call cumulative brain injuries. A small residual of that damage remains in that brain. However, when SIBO occurs before 5 years, the child usually experiences a development delay. But if SIBO occurs after the age of 5, the child will not show developmental delay, but will show some features of the cumulative brain injury. You see in this graph, before 5 years and after 5 years, the features of cumulative brain injuries can differ because of the defective pruning. The abnormal neurological functioning from the cumulative brain injury can occur slowly over time, or sometimes it occurs rapidly, depending on the intensity of the brain injury. Damage to the different parts of the brain will result in different outward symptoms, some with ADHD, some with anxiety, some with autistic behavior. In addition to these changes, excessive inflammatory environment in the brain reduces the seizure threshold and make the seizure more likely to occur. The drop in the seizure threshold from inflammation is seen when the young children without autism develop febrile seizures, like febrile seizures, so that we see more seizures with autistic children. How to solve this problem? There had been a lot of reports, especially during the last 3 or 4 years. One of them was the Nemechek Protocol. We will discuss the points in the Nemechek Protocol. Well, rebalancing the gut microbiota can be done by inulin. This is a prebiotic dietary fiber, a FOS derived from plant sources. It's not absorbed during digestion and enters the intestine, where it ferments and lowers the pH of the intestinal lumen, changing the composition of the microflora, restoring the normal bacterial contents of the bowel. The daily oral administration of the powdered inulin, or there are gummies of inulin, starting with low dose of 1/8 teaspoon or equivalent. The dose is gradually increased until the patient achieves an improvement in the eye contact and awareness of the family members what we refer to as awakening. In children over the age of 10 and adults, probably inulin is not much sufficient to achieve an awakening. The non-absorbable antibiotic rifaximin in a dose of 550 milligram twice daily over a course of 10 days can achieve the same purpose. In addition to changing the bacterial flora in the bowel, we aim to reduce the inflammation and repair the brain. The DHA and EPA are very helpful in this task, in addition to omega-9. Extra virgin olive oil is 70 to 85% oleic acid. This is capable of attenuating the inflammatory effect of excessive omega-6 linoleic acid. The two oils are essential components of this protocol. They not only provide essential nutrients for the brain, but also counterbalance the high levels of inflammatory omega-6 oils. This table shows the dosage of the omega-3 in children according to the age. You see, with increasing age, the dose is increasing. In infants, small infants, it's around 150 milligram, while in those near adolescent and adults, it's over 2,000 milligrams per day. In some instances, the awakening period was characterized by extreme levels of anxiety, aggression, or emotional sensitivity. It was disruptive to the family and dangerous to the patient and caregivers. In that case, inulin was temporarily discontinued and the oils were administered for 6 to 8 weeks to allow some improvement in the emotional regulation before reintroducing inulin. The delayed introduction of inulin slowed the rate of neurological recovery, but allowed for bacterial overgrowth and the sedative effect of propionic acid to return. When inulin was reintroduced later, a less emotionally intense awakening was observed. The patient rate's recovery seemed to accelerate. Additionally, patients were counseled to avoid dietary sources of omega-6 containing oils as much as possible. Over the course of the first 2 to 4 weeks after introduction of inulin, parents noticed that their children display greater improved eye contact and acting more connected with the world around them. They started seeking out parents for comfort or they needed something and began making more purposeful gesturing. This initial period we refer to as awakening. During this period, sleep patterns were variable during that period, but they improve within several weeks. The items to follow during recovery were speech, sensory items, socialization, attention focusing, meaningful play, aggression and self-injuring behaviors, motor skills and tone, communications, receptive and expressive, in addition to intestinal functions. The awakening is likely due to removal of the sedative effect of propionic acid produced by the SIBO. This period occasionally can present with increasing stimming, aggression, odds behavior, loud noises, disturbed sleep patterns, and increased emotionality, along with constipation. These symptoms commonly resolved after the next few months with continued adherence to the protocol. Most exciting for parents was the return of speech or initiation of the first few sentences for the first time. Interference from other supplements, especially probiotics and digestive enzymes, were found to interfere with the success of that protocol, and they were strictly avoided. Most patients were able to continue the use of nutritional and other supplements without consequences. Notably, the overuse of unnecessary vitamin, enzymes, or antibiotics and other supplements was also interfering with the success of this protocol. In conclusion, we see that recent researches demonstrate a connection between autistic spectrum disorders and the gut microbiome, highlighting the need to more fully understand the gut-brain axis and how bacteria residing in the gut influence mood, learning, attention, awareness, development, and most immune function. Thank you very much for listening.
Thanks a lot, dear professor. It was an awesome lecture. Autism is one of the rising problems all over the world. However, there is a lack of understanding, knowledge about it. So it's very good to know this, and thanks a lot for sharing your knowledge with us. Thanks a lot for giving us your time. I want to pass the microphone to dear Dr. Memar. She want to discuss about some points with you, dear professor. Dr. Memar.
Thank you, Thank you, doctor. It was great. We enjoy a lot. I have a question. As you know, autism is not very rare, and there are a lot of articles about relationship between autism and diet. I want to know that is there any relationship between gluten and autism?
Yeah, for sure. There is. This is a new concept. It's not, let's just say, ignoring the old ideas, but it adds on. Yes, diet, we say those that are rich in omega-6 can be harmful for these children. And diets rich in omega-3, omega-9 can be very helpful. In the old days, there has been a lot of dietary restriction to these patients, dairy products, glutens, but they are well associated with limited success. But the new concept is that these dietary components help in the recovery of the injured brain. The concept is that the brain can recover. It's no longer that in the old days that a damaged brain cannot recover. Yeah, and these microglia, the function is improved with these dietary entities.
Thank you, Dr. Smith, for sharing your points of view. Thank you.
Thank you.
Dear Professor Adnan, can I kindly ask you to stay with us up to the end of session? So if there is any question come up with your point of view, I will share with you.
Okay, thank you.
Many thanks. Thanks a lot. I'm sure all of you enjoy Professor's lectures as much as we do. We are going to have the second lecturer. I'm going to introduce you, dear Dr. Ibrahim Khasraw. He is an assistant professor at College of Medicine, University of Sulaimani, and also he is consultant pediatrician and pediatric neurologist. It's a big honor to have you with us, dear Dr. Ibrahim, if you have my voice. Dear Professor Ibrahim, if you have my voice.
Yes, I hear you.
Hello, dear Professor.
Hello. Good afternoon. Thank you very much for this participation in this conference. I am glad to present a few notes which are extremely important among children as a behavioral disorder, which is about breath holding attacks, which many times this behavioral disorder misdiagnosed and mismanaged as epileptic seizure and treated in the wrong way.
Dear Professor, you could share your slides and start your presentation.
Yes. Breath holding attack, it is said that it is non-epileptic. It is non-epileptic paroxysmal event characterized by voluntary holding of breath after a prolonged inspiration. So there is prolonged inspiration followed by involuntary apnea during expiration. Usually it starts in 6 to 18 months of age, but can't start in first few weeks of life. Can start in first few weeks of life. So it may occur in very small age children. About 10% of it starts after second year of life. Range to many attacks per day to once a year. Precipitated by emotional excitation, anger, and frustration. It is benign for the patient, but very frightening for the parents, and the incidence is around 4.7% among children. It is said about this behavioral disorder, many references, but the oldest one is the scientist called Carpet Pieper, who said that there is a disorder in children from anger to grief, when the spirits are much stirred and run from the heart to the diaphragm forcibly and hinder or stop the breath. When the passion seed, this symptom seed, this is in around 1730 before in years. Later on in 19th and 20th is like this. A decrease in frequency in the second year of life. By fourth year, about 50% of them will cure. And by 7 to 8 years, all of them cure from this behavioral disorder. And about 30% of them, they get syncopal attacks in the future. Complications are very rare. Few deaths reported due to aspiration in prolonged attacks and in those who had respiratory or significant medical problems. The sequence of events which occur during the attack, it is found that there is excessive or strenuous crying for less than 15 seconds. So it's occur in the onset of the crying. Then the child holds the breath in expiration, followed by getting apnea, then cyanosis. Here may end the problem and the child recover, but may continue the pathological or the abnormal process, may pass to brief loss of consciousness and limpness. Then opistotonus for 1 minute and few gaspings, then the child fully recover as if nothing has been happened. Facts about it. It's found that some get cloning movement of extremities with urinary incontinence in some and fecal incontinence in few of them. This make the false diagnosis of epileptic seizure and make the pediatrician to deal with this condition as epilepsy and they give hazardous drug to those children. All of these events usually last less than 1 minute. And some of them sleep for several hours at the end of this behavioral disorder. So it is to be taken that this is not a post-ictal state of epilepsy, and the event which occurred was not epileptic seizure. Previously, they thought that it occurs in spoiled children or be a sign of bad child-parent relationship. And others say that it is non-volitional and can be equated with temperamentally difficult child. Regarding the pathophysiology of this behavioral disorder, there are many studies, clinical studies and explanations done, but exactly not well known, and they found that it is a complex. During attacks, found that by fluoroscopy, there is higher position of the diaphragm. So that's mean full expiration. During full expiration, there will be highest position of the diaphragm, and it was motionless during apneic period. And in other study, there was spasm of glottis and respiratory muscles and increase in intrathoracic pressure, which causes a decrease in cardiac output, then decrease in cerebral perfusion. That's the main pathology which occur. And violent crying cause hypocapnia with further suppressed cerebral circulation. As we know, hypercapnia make the cerebral blood flow more, and hypocapnia make it less. So there is usually impairment of cerebral perfusion. In other study, they found that partial pressure of oxygen within 20 seconds of the attack was less than 20 millimeter mercury. And after 30 seconds, there was loss of consciousness. So the matter here is related to the hypoxia or hypoxemia. Then they found that there is no intracardiac shunting, but could be due to intrapulmonary shunting. Still, this point is rising and significant. There is no central or peripheral neural respiratory control functioning, but there is inadequate lung volume. This is another explanation for what happened to the respiratory system during breath-holding attack. Other studies found that there is excessive compliance of rib cage, which allows transient alveolar collapse. So there may be during the cyanotic attack or the breath-holding attack, there is transient alveolar collapse. In another study, they found that krypton infusion scan, which is a radioisotope scanning of the lung, special type of scan, showed leakage of krypton outside the lung field without intracardiac shunt. Means that there was intrapulmonary during hypoxemia. Still, another study showed that ventilator chemosensitivity has a role and resolve with maturation of brain and lungs. Because of this problem, when the child become older, they improve. Another study showed that majority has adenoids, adenoidal hypertrophy, and removal of them or doing adenoidectomy for those children cause curing of the problem. So they related to the upper airway obstruction, which is induced by adenoidal hypertrophy. Another study they did on by polysomnography, they showed that there is decrease in eye movement during rapid eye movement sleep. So they return back the whole pathological process to the quality of neurotransmitters which are responsible for rapid eye movement sleep. In the other explanation, they found that brainstem auditory evoked potential showed there is abnormal function of the brain. There was 3 to 5 and 1 to 1, which is a special characteristic finding in brainstem auditory evoked potential interpeak latency. Still, they did many other studies on this process. In one other study found that autonomic nervous system disorder is a factor. They found that it is after standing from supine position among those children, there was increase in pulse rate at 15 seconds and decrease in diastolic blood pressure with no increase in systolic blood pressure. This finding explained by sympathetic overactivity, which causes intrapulmonary shunting. Then, at the end, they found that there is a great role for iron. Iron has a role, as we know, in catecholamine production and metabolism and in neurotransmitter function. And they return back the part of this behavioral disorder to abnormality in iron metabolism. And they say that in the other study showed that there is a role for oxidants and antioxidants. How? They found that there is malonaldehyde indicator of free radical generation was significantly, which are oxidant, higher among those children, among the blood of those children. And glutathione peroxidase and superoxide dismutase, which are removal of the oxidant radicals, was reduced. So there is increased production of radicals and oxidant in their blood. And they found that selenium, which is a cofactor for glutathione, usually reduced among those children. Diagnosis. For making a diagnosis, the clue is history. History is very important of the events by witness, and video recording by mobile is better than only description by the person. EEG, which many times done as if the child has epileptic seizure, it is not indicated at all, except attack of prolonged seizure or atypical events occur. Shows usually slow or suppression of voltage. ECG, it is inversely to the EEG, should be done for every child with breath-holding attack to exclude prolonged QT syndrome. As we know, prolonged QT simulating these attacks, which is a differential diagnosis. Genetic background. They found that 23 to 38% of those children have family history of breath-holding attacks. So it could be a genetically determined problem. Some have members with palate and others with cyanotic spells in the same family. Also, they found that in the same child, both types of spells may be present. Palate spell they found also male to female ratio. Male is 1 and female 1.2. So it is found that it is more common among female. Risk of transmission from parents found that to be 50/50. And in 7% of those cases, there was father to son transmission. So there is that one exclude X-linked mode of transmission, as we know there is no father to son transmission in this mode of genetically determined diseases. Then proved by pedigree study that it is autosomal dominant with weak penetrance. This is the lastly agreed on the mode of transmission. About palate spells, it is due to increase. They found that it is due to increased vagal tone and decrease in cerebral perfusion. There is marked bradycardia to asystole. could be enforced by ocular compression for 2 seconds. So we can induce this behavioral disorder. Produce asystole in 78% of cases due to transmission of afferent signals to the brain stem via the ophthalmic branch of trigeminal nerve and efferent parasympathetic signal from vagus nerve. So they say that this is brainstem discharge phenomena. It may occur without crying, when the child is frightened or surprised, when it is prolonged for more than 1 minute and followed by a seizure. It is called reflex anoxic seizure. 23% of them in both types have hemoglobin less than 8 grams per 100 ml, and found that asystole more prolonged among anemic children. 51.5% of them whom treated with ferrous sulfate got complete remission, and 36.4% of them, they had 50% reduction in frequency of attacks. 20% of them cured by iron therapy, in spite of having normal iron status. But in some cases, in spite of being they are iron deficient, they didn't respond. For iron status, they depend on serum soluble transferrin receptor level, and they found that it is the earliest indicator of iron deficiency. Regarding the treatment, reassurance is very important. Breath-holding attack is a benign condition and self-limiting, does not cause epilepsy or mental retardation in the future. So reassurance of the parents is extremely important. During the attack, put the baby in recumbent lateral position to prevent cerebral anoxia and aspiration. As we said, these are two problems which may cause mortality or morbidity to those children. And no CPR, cardiopulmonary resuscitation. Don't do cardiopulmonary resuscitation even if the condition was prolonged, because they found that it is more harmful rather than useful. Regarding the drug treatment, they found that iron is important and better to be given even if the child is not deficient in iron or he is not anemic. Atropine. It is found that atropine 0.01 milligram per kg per day is effective for palate spells, but rarely indicated in clinical practice because of other side effects, because of not reliable daily giving atropine, and because of non-compliance. Fluoxetine, which is a anti-anxiety drug, antidepressant drug, slow release serotonin reuptake inhibitor, showed that 50% they have efficacy and 40% decrease in frequency of the attacks. Levetiracetam, it is present under the trade name of Keppra, which is a major anti-epileptic drug, found to have that among those children prevent asystole and or loss of consciousness, but does not prevent the breath-holding attack sequences. Glycopyrrolate and thiophyllene combination found that prevent loss of consciousness but not breath-holding attack also. Anti-epileptics. What about anti-epileptics? Found that even if seizures occur, true seizure, it is short-lasting. No need to prescribe anti-epileptic. And no anticonvulsant needed, but may prolong and cause status those who have low threshold for seizure. Some of those children, they have low threshold for seizure and they get status epilepticus by breath-holding attack. And those among those children may be Pyracetam, a drug, is widely used, I think, among pediatricians for this purpose. 40 to 100 milligram per kg per day, found to be effective. But still, it is not FDA approved for this problem. It is approved for refractory myoclonus. but in other countries, in other protocols, it is found to be effective. And the mechanism is it has chemical structure similar to GABA, which is inhibitory neurotransmitter. And thank you.
Many thanks, dear professor, for your awesome lecture. We enjoyed it a lot and also learned a lot. Thanks a lot for giving us your time and also sharing us your knowledge. I will pass the microphone to Dr. Memar to discuss something about the lecture with you, dear professor. Dr. Memar.
Thank you, Professor. Thanks for sharing your knowledge, and also your lecture was great. I have a question. It's my own question. I want to know, how can we differentiate between a breast-holding attack from seizure in infant, according to your experiences?
Actually, according to witness is very important, because the sequence of events in seizure, usually the child lost consciousness and then get cyanosis. But in breath-holding attack, usually the child get central cyanosis around the lips and then get seizure after that. And usually in epileptic seizure, the electroencephalography EEG is sometimes helpful, which is normal usually in breath-holding attack, but usually in epileptic maybe abnormal. Also, normal EEG does not exclude epilepsy. So the sequence of events is extremely important to be described or to be seen. Sometimes mentioned if nobody has seen the child during the attack, or you don't have video of the event, you can show the video to the witness person, to the caretaker. Does the child in this way? If yes, clinically you can decide that this is breath-holding attack and this is not a true seizure.
Thank you, dear Professor. I myself learned a lot. Thank you a lot.
Thank you very much.
Just dear professor, I kindly ask you to stay with us up to the end of the session. So if any question come up, I could ask you. Thanks a lot.
Thank you.
Many thanks too. Let's move to the next lecture, the third lecture of this session. I want to honorably introduce you, dear Dr. Khalaf Hussein Gargary. He received Bachelor of Medicine and Bachelor of Surgery degrees, Diploma in Health, in Child Health, Certificate of the Arab Board of Pediatrics, Fellow of the American Academy of Pediatrics. Dr. Khalaf is Professor of Pediatrics working at University of Duhok and Consultant Pediatrician working at Hivi Pediatric Teaching Hospital and Wajin Private Hospital in Iraq. And also he is President and founder of the Joint Iraqi-Italian Pediatric Association. We are very pleased to honor and have Dr. Khalaf with us. I'm going to share his presentation that then he is going to be with us in question answer. If you have any question about dear doctor's lecture, please ask in chat section.
Thanks goes to our organizing committee for their kind invitation to deliver this presentation. Actually, this is a chapter in a book, and I'm going to try to summarize it in like less than 20 minutes. Talking about childhood behavioral disorder, actually in the recent years, there were a lot of progress in understanding of the child behavioral disorders. As we are more aware about many of the diseases, we were not so aware about them in the previous decades. Talking about the child behavioral disorder, first of all, we talk about developmental psychopathology. which studies the disorders within the context of a normal child development and relationships between the child and adult psychopathology. You know, some of the these disorders are unique to children, like separation and anxiety disorders, while some disorders are primarily childhood disorder, but they may continue until the adult life, like the attention deficit hyperactivity disorder, which you all know. And some of the disorders are present in children and adults, like depression, although it's not so common in children. The DSM-5 split childhood disorder actually into 2 chapters: the neurodevelopmental disorder, disruptive impulsive control, and conduct disorders, the 2 groups. And also there are some changes in the names for some disorders, like mental retardation is no more used. We call it rather intellectual disability or intellectual developmental disorder is preferable over the old name of mental retardation. You see, we have a group of disorders like intellectual disabilities, specific some learning disorders, autism spectrum disorder, motor disorder, communication disorder, ADHD, feeding and eating disorder, disruptive and some impulsive and conduct disorders, and anxiety disorders, including adult disorders as well. So I'm not going to go through all of this. I'm sure some of them have been covered by other colleagues. I am going to go shortly about some of the other childhood behavioral disorder. We divide them into the externalizing disorders, which characterized by outward directed behaviors of the patient, with non-compliance, some aggressiveness, some overactivity, impulsiveness, which includes the main one is the ADHD, which we all know. Also with that, we have the conduct disorder and ODD, oppositional defiant disorders actually can occur. And this is actually more common in males, more common in boys. While the internalizing disorders, it's characterized by inward focus behaviors like depression, anxiety, and some social withdrawal behaviors. It includes childhood anxiety and some of the mood disorders, which can occur more commonly in girls than in boys. Talking about ADHD, there is excessive level of activity actually, like fidgeting, like swimming, like running around when it is in an appropriate place, like insistent talking when it's not time to talk. Some distractibility, some difficulty in concentration, which makes them to do some careless mistakes. They cannot follow the instruction, and this makes a lot of problems, especially at school age children, and some forgetfulness also. It will be problematic in the children in the schools. They may have difficulty with peer interactions, and this is one of the major problems in those patients. The criteria for ADHD disorders, it is either A or B. A, 6 or more manifestation of inattention present for at least 6 months to maladaptive degree, and greater than that would be expected in a person with that developmental level, like careless mistakes, like not listening well to others, not following instructions and commands, easily distracted, and some forgetfulness in the daily activity. They forget very frequently. Or B group, with 6 or more manifestation of hyperactivity and impulsivity present for like 6 months to maladaptive degree, the same way, like fidgeting, like running out inappropriately. Sometimes in adults, they don't run out, but rather they are restless. And acting as if they are driven by a motor, as if they are not controlling. So this will cause interruption and intruding others. Insistent talking, sometimes they talk insistently. Several of the above are present before the age of 12 months, actually. Presence or 2 more of settings at home, at school, and at work. So in different places you can face those problems. They have some significant social impairment, some impairment in the academic and occupational functioning, actually. For those who are older than 17, 5 signs of inattentions or 5 signs of hyperactivity, impulsivity is required to meet the diagnosis of ADHD, not like those who are younger than 17, which need 6 criteria. So the 3 specifier in DSM-5 to indicate which symptom predominate, it is either predominantly inattentive or predominantly hyperactive, impulsive type, or sometimes it's a combined type. Combined type is more common, and we see commonly in pediatrics rather than the other 2 types. Actually, the differential diagnosis, is it conduct disorder or ADHD? In ADHD, they have more off-task behavior. They have cognitive and achievement deficits and academic deficits. While the conduct disorder, they are more aggressive. They are out of most sitting. They have some antisocial parents. They have family hostility, actually, which goes more with conduct disorder rather than attention hyperactivity disorders. So if you see, there are some comorbidities, actually, and we can see adolescents with ADHD or without ADHD. So it's often comorbid with anxiety, also sometimes with depression because of their bad behaviors. The prevalence is expected to be between 10 up to 11. International speaking, public policy can affect the diagnosis rate because, you know, it is diagnosing a case in Iraq and Iran, not like diagnosing a case in European countries. And they are more common in boys than girls. And always they said boys are boys. And sometimes this may give them an excuse to be hyperactive, actually. And sometimes because the boys' behavior are more likely to be aggressive. And sometimes we encourage them to actually really. Symptoms persist beyond childhood, usually. Numerous longitudinal studies, they found that up to 80% of them, they still have some symptoms, but they are not hyperactive. They may be restless as adults. And also, maybe up to 60%, 2/3 of patients, they may have the criteria for ADHD, but they are in remission in a way or another. While girls with ADHD, if you see Hinshaw et al., it was a large study. They found that it's combined type. More disruptive behavior than inattentive one, more comorbid diagnosis like ODD than in girls without ADHD, if we see them. The inattentive type, they view more negatively by peers than girls without ADHD. Girls with ADHD are more likely to be anxious and depressed more than boys. They may exhibit some neurological deficits like poor planning, like problem solving. And they have symptoms of eating disorder more than boys and even substance abuse by the adolescent age. The etiology, genetic factors play some role. In adoption and twin studies, they found that heritability is account for up to 80% of them. And there are 2 genes, 2 dopamine genes, DR4 and DT1 are responsible. Other genes are associated with increased risk when there is prenatal maternal nicotine, smoking, or alcohol is present in those patients. So always we encourage mothers not to smoke or take alcohol during pregnancy. Although in our religion it is forbidden to drink alcohol, we all know that. And neurological factors, dopaminergic areas in smaller is smaller, and they found by MRI. They found that it is smaller in children with ADHD when compared to normal in the frontal lobes, in the caudate nucleus, and even in the globus pallidus. And they have poor performance on tests of frontal lobe function when we do for them. Prenatal and prenatal factors, you know, low birth, where they found that it is related, but not always. Maternal tobacco, as we stated, in the presence of genetic, it will make it more and more. Environmental toxins, actually, there is limited evidence. You know, years back, we were talking about some additives, some sugars, and some type of food, but no evidence found that refined sugar can cause ADHD. Actually, nicotine from maternal smoking has a rule. Exposure to tobacco in utero is associated with ADHD symptoms, and if there is genetic predisposition, it makes it more. Many damage to dopaminergic area resulting in some behavioral disorder due to maternal smoking can occur. The relation between the parents and the child, parents usually give more commands and have more negative interaction with babies. Family factors interact with genetic and neurological factors and environmental factors. All of them contribute together to come into the surface. They may contribute to or maintain the ADHD behavior, but do not cause them actually. So it makes them to come to the surface, but the genetic predisposition is almost there in more than 80% of cases. How to treat them? Stimulant medication, Ritalin, and others. It reduces actually the disruptive behavior. It improves interaction with parents, teachers, peers, and actually in the school, it's a big problem to have a patient or a child with ADHD. It reduces aggressiveness because, you know, most of them, they have aggressive behaviors. It's effective in about 75% of children with ADHD, but also, they have side effects of appetite, weight, and sleep problems are real problems. Medication plus behavioral treatment, the MTA study, it's slightly better than medications alone. It improves, in addition, it improves the social skills where medications alone did not do that. 3 years follow-up found that superior benefit if you of meds did not persist, while if you do behavioral therapy, it persists after that. Psychological treatment is part of the important part of the treatment. Parental training, sharing the parents in the education entry is very important. Changing in the environment, changing in the classroom is very important. Behavioral monitoring and reinforcement of appropriate behavior and may play a good role in those patients. Supportive classroom structures, brief assignment, immediate feedbacks, task-focused style, giving them short tasks, and breaks for exercises because they are hyperactive and sometimes doing exercise reduce this energy and this hyperactivity. While talking about conduct disorders, they are pattern of engaging in behaviors that violate the social norms in the area and the rights of others and are often illegal. So they have aggression, they have cruelty toward other people or even toward animals, damaging properties, dying, stealing, vandalism, often accompanied by callousness and lack of remorse, actually those behaviors. If you see the related disorder, conduct disorder, they have intermittent explosive disorder like recurrent verbal or physical aggression outbursts out of proportion to the circumstance. You see, there is a simple behavior from a person and you see that they act very aggressively against them in an impulsive way, which is not expected to be there. ODD, oppositional defiant disorder behavior, do not know the criteria for the contact disorder, especially extreme physical aggressiveness and bullying with children. But child may display some defiant behaviors within conduct disorder, like argumentative, like loss of the temper while talking to other, lack of compliance, some hostile behavior, some spiteful or touchy or blaming others for their own problems can occur in patients with conduct disorder. sometimes the conduct disorder is combined with ADHD, with learning and communication disorders, and this will lead to disruptive behaviors of ODD, more deliberate than ADHD when it is alone. Most often, it's diagnosed in boys and maybe as prevalent as girls, but we can diagnose because girls are more introverted. We can diagnose them more oftenly. DSM-5 criteria for the diagnosis of conduct disorder, I'm sure you all have come through this, like repetitive persistent behavior, aggression to people and animal, we stated before, destruction properties, self-seeking, vandalism, and other breaking into others' house or car, also serial violation of rules, staying out of line before they are old enough for that, not obeying their parental commands, significant impairment of their social, academic, and occupational functioning of care. So substance abuse is common between them, but it is unclear. Is it precede it or it is concomitant with it? Till now, it is not clear. Comorbid with anxiety and depression, comorbidity like up to 45% of cases. Conduct disorder, actually, they may precede anxiety and depression, and then the patient tend to have depression or anxiety. In boys, it is a little more common than in girls. 16 in boys up to 16, while 1 to 9 in girls. You see, and this is the age for patients to have aggressive behaviors. So we have two distinct types of conduct disorders. First is the life course persistence pattern of antisocial behaviors. It is like 10 to 15 times more common in boys than in girls. While the other type is adolescent limited, maturity gap between physical maturation and rewarding adult behaviors sometimes occur at this age, and this is the second type of conduct disorder. Some longitudinal studies of life course persistent type showed that more severe problems into early adulthood includes like academic underachievement, like ADHD, some neuropsychological deficit, family psychopathology, like lower self-esteem, poorer physical health, and some violent behaviors in the society. So if you put them together, we have either psychological, social, or neurobiological, all of them together, they interact with each other, leading to the conduct disorder. The etiology genetic factor is likely to play a role as a part. The twin study data show that there are mixed studies. It may be environmental, but still genetic has some role. Adoption study focus on criminal behavior, not conduct disorder, and because of that, it cannot depend on them. The meta-analysis of twin and adoption studies suggested that up to 50% of antisocial behaviors is heritable. So still, up to half of them, it is environmental rather. Genetic has stronger influences, actually, when the behavior begin in childhood rather in adolescent age, while in adolescent, it is more than it is environmental exposure to the environment. Genetic and environment, usually they interact together. Abuse as a child plus low activity, more likely to develop conduct disorder. So neurobiological factors like poor verbal skills in early years of life, difficulty with executive functioning, low IQ, some of them, they have low IQ, lower level of resting skin conduction and heart rate suggests that they have lower arousal level than the normal population. Some psychological factors like deficient moral development, especially in the lack of remorse, in the lack of education, modeling and reinforcement of aggressive behavior is very important, and sometimes it's absent. Harsh and inconsistent parenting and fortunately in our area, we have big families and we don't face this problem. Lack of parental monitoring, actually, as I stated, we have other people, we have big families, we have extended families, and some cognitive biases like neutral acts by other perceived as hostile. Maybe a simple behavior from someone is perceived from other one as it is a hostile behavior or a violent. So it is like a theory of agreement, like a vicious circle. We have ambiguous act interrupted as hostile. This leads to aggression against others, and this leads to retaliation from others, and this will lead further aggression, and aggression lead to ambiguous act against others, and this is we should work on this to break this vicious circle. Peer influences associated with conduct disorder, rejection by peers, sometimes, especially in adolescents, not in children. Affiliation with deviant peers sometimes has some role. Socio-cultural factors, some poverty, urban environment, not living in cities has some role. Higher rate of delinquent acts among African American men is linked more to living in poorer neighborhood rather than the rest. So it is not a genetic predisposition rather than living in a poorer area with low social classes. Treatment is very important. Family intervention, family checkups is very important. Usually is associated with this disruptive and aggressive behavior. Parental management, trained PMT is very important. We teach the patient to reward the pro-social behaviors, to give rewards for the good behaviors of the children. Actually, it is multidisciplinary therapy. We deliver intensive community-based services, and this is very, very important. You see, in children with conduct disorder, the child is living in not in a separate place. So there are caregivers, there are siblings, there are extended families, there are peers, there are neighborhoods, there are school and schoolmates, there are some provider agencies, and the biggest one is the community. So all of these should approach the children with conduct disorder and help them to go through this problem. Depression and anxiety in children and adolescents, it commonly co-occur with ADHD or conduct disorder. Sometimes they can co-occur with each other, depression and anxiety. Researchers they found that depression and anxiety could be distinguished from each other in the same way they are in adults. So there is no much differences. In depression, there is high negative effect, low positive effect, while in anxiety, high negative effect, but no low level of positive effect. More recent research called for finding this into question and which one goes with which. Depression symptoms are common in children and adolescents and adults, like depressed mood, inability to experience pleasure and being happy, always feeling fatigue, problem in concentration, especially in schools, and some suicidal ideation. Symptoms specific to children and adolescents, like higher rates of suicide attempts and guilt, lower rate of early monitoring, early morning awareness, early morning depression. They have loss of appetite, they have loss of weight, and they have low self-esteem. Prevalence in preschoolers is less than 1%, while school age it's more, up to 3%, 6% of girls and 4% of boys. During adolescent, they have also some depressive disorders. Etiology, genetic factors, not very clear actually. Early diversity and negative life events experience, family and relationship factors. A parent who is depressed may have role. Parental rejection, children with depression and their parent interact with negative ways. They have less warmth and more hostility at home. Cognitive distortion and negative attributional style in the life may play a role. They have stable attributional style they develop by early adolescence. They by mid school or later on they have some cognitive diastasis, and this can be explained as depression. Treatment, actually, medications, we use cyclics. Sometimes meta-analysis show that medication are most effective for anxiety other than obsessive compulsive disorder. They are less effective for depression and OCD also. Concerned about medications because of the side effect causing GI problems, sleep problems, and agitation possibility. It increases the risk of suicide also in those children. While interpersonal psychotherapy is very important and it has a big role in treatment. It focuses in peer pressure and also some issues related to the independence is very important in those patients. While behavioral therapy, behavioral therapy is very, cognitive behavioral therapy is more effective for Caucasian adolescents than those with pre-treatment. And good coping skills if you do cognitive behavioral therapy and prevent recurrent depression also. Psychotherapy generally only modestly effective in those children, especially in adolescents. And cognitive behavioral therapy is no better than non-cognitive behavioral therapy in dealing with those children. We always need the medication. I am going to stop here. I don't want to take more time. Actually, this is a very big subject. So I'm going, because there were some learning disorders, autism, spectrum disorder may be covered by other colleagues. Actually, post-traumatic distress is also a problem in many children. Anxiety is common in those children, but because of the shortage of time, I'm going to stop here, and thank you very much.
Many thanks to dear Professor Khalaf for giving us his time and also sharing this awesome lecture with us. Unfortunately, up to now, we don't have dear Professor Khalaf with us. So we will waiting for the end of the session, up to the end of the session for asking the questions. Kindly let me introduce you the next lecturer. I'm honorably introduced dear Dr. Sasan Lokaf, Fellow of the Iraqi Commission for Medical Specialization. He's a lecturer of pediatric at Hawler Medical University and head of pediatric department in Rebalancing Teaching Hospital. It should be noted that he is pediatric consultant in the Emirates Center for Autism. Dr. Loqa had many publications in neonatal sepsis and congenital heart disease in Erbil, research on thyroid function tests and different mode of delivery, and others. It's a big honor to have dear Professor Loqa with us. How are you, dear Professor?
Good afternoon. Thank you for inviting me to have participated in this conference and sharing with you a subject which is important. And I think there's some discussed by the Professor Khalaf about the hyperactivity disorder in the pediatric. So the outline, we are discussing some important point about the temperaments, different temperament of the pediatric, hyperactivity, and also this we have attention deficit disorder. As you know, we have the 4 temperament in the pediatric and also in the adult. That this is from the birth, just either do in physical appearance. And most of these temperament are genetically determined. And this is affect how other people deal with them. And we have a sanguine, choleric, melancholic, and we have the phlegmatic. So this is from the birth started. They have this temperament. The difficulties or difficult temperament is prone to. So they are predominantly negative mood, that is winning, mowing, crying. And also they have intense emotional reactions, screaming rather than whimpering, jumping from joy rather than smiling, irregular biological function, a lack of rhythm in sleeping, hunger, or toileting. So they have difficult to go to these three important points. Negative initial response to no situation, example, pushing a new toy away, protracting adjustment to new situation, taking weeks or months to settle into a new playground. These temperament is starting from the birth, and this is affect the child starting crying. This we have no settling, and this is from the birth is determining. So hyperactivity. So when their level of motor activity exceeds that regarded as normal, they may be termed hyperactive by the parent. So not mean that all the children which is hyperactive by the parent mean that this child have hyperactivity disorder, but it is hyperactive. Judgment that depend upon the parent's standards and expectation. The term can thus incorrectly be used. Such a child is not hyperactive, but the parents need advice about how to handle unwanted behavior. So this is a case in brief. The parents of a 7-year-old boy take him to the family practitioner because they have become increasingly concerned about his behavior, not only in school, but also in home. In the 1st grade, he has been bored, disrupted, fighting with classmates and rude to his teacher. At home, he cannot sit still, and meals have been very unpleasant. The lad himself wondered why he is there. The parents have 2 older daughters who say their brother is a pain and spoiled. There were no pregnancy or birth problem, and the child is on no medication. The doctor decides more information is required before any treatment is indicated. So before starting any management, you should be sure that is any investigation you need to diagnose the condition. He wants careful observation of the child both at home and in school. It means that the problem not only in the home, also in the school. He wishes to talk with his teacher and suggest psychological testing. He also wants some time to see the patient at home. Careful investigation and thorough observation must be done before any intervention. Both the physician and the parent are concerned about overuse of medications and the value of behavior intervention. This is a simple case. It is daily. We can see in our daily practice. So about a case which is hyperactive and how we deal it and how you start management before starting management, the investigation to be started. So you have what's called attention deficit hyperactivity disorder. As we notice, we have about 6.4 million American children aged 4 to 7 years have been diagnosed with ADHD worldwide. Is a mental disorder that most often occur in children. So attention deficit hyperactivity disorder is a neurobehavioral disorder defined by symptoms of inattention, hyperactivity, and impulsivity. We have the 3 important cardinal of symptoms: inattention, hyperactivity, and impulsivity. There is no evidence that ADHD is due to a single gene, or no evidence of any single gene, but most of the ADHD run in some families. In some family, they may be some genetic under what is the genetic cause of that. So ADHD can be seen in children who have developmental disorder, including fetal alcohol syndrome, Down syndrome, as well as in children who have had varying level of brain injury, include perinatal brain damage. Most commonly, there is no identified cause of ADHD. So maybe it is genetic, organic, environmental, or maybe it is combined. That is maybe due to the combined genetic and organic or environmental together. The epidemiology, the estimated prevalence of ADHD in the United States is too much in the school age children, about 8 to 10%. So it is twofold more in boys as like in autism than in the girl. And the girls is likely to be diagnosed with inattentive type of the ADHD. So most of the symptoms persist to the adolescent, about 60 to 80%, and some of them may continue to have symptoms into the adulthood. The clinical manifestation, the phase we depend on the history. So we have the ADHD specific rating scale, and this is mostly specific and safe for diagnostic ADHD. In the examination, it is the first important to rule out medical or developmental problems, and observation of the child and the parent and their relationship. Laboratory and imaging study are not routinely recommended, and mostly if it is need, mostly to rule out other condition if it is suspected. Most of them sometimes need to send for the thyroid function test, lead level, and genetic karyotyping and brain imaging study to exclude other conditions. I don't go in detail about this criteria for diagnostic, and I think most of them mentioned by Professor Dr. Khalaf. So it is we have the inattention, as they mentioned, is we have the 6 or more of these criteria, more at least should present for the 6th month, should present for the 6th month or more. This is inattention. The second one is we have the hyperactivity, also should have the 6 or more of these symptoms should be present and should be persist for the 6th month or more. And the third one, it is we have the impulsivity. So these are the criteria. Mostly it is done by a pediatrician, or we have the special child psychiatrist to diagnose for the attention deficit hyperactivity disorder. So what are the differential diagnoses? We have the hyperthyroidism or lead intoxication. We have the chaotic living situation, speak language delay, and learning disability can occur with ADHD. This is mostly because we have that the screening, this TV, video games, aggressive, so it is maybe the causing of ADHD or maybe associated with the AD, and both of them may causing this delay in the language and this also learning disability, and they are mostly can occur with the ADHD. We have psychiatric conditions such as conductive disorder, depression, and anxiety disorder are more common in children with ADHD than in the general population. This is the differential diagnosis. About the management, we have the first thing, you should tell the family that this is a chronic condition, and education affect children and their parents about the symptoms of ADHD and strategy to control overuse effect and an effect on the learning, school functioning, social relationship, and family life. We have first started from the behavioral approach to accommodate their condition, and most it is we have the for the behavioral approach. It is helpful to provide structure, routine, and appropriate behavioral goals. Some children benefit from social skill counseling. The second one, we have the stimulating medication. It is effective for managing the symptoms of inattention, hyperactivity, and distractibility in most children with ADHD. We have the short-acting, intermediate-acting, and long-acting methylphenidate, that's Ritalin, and long-acting dextroamphetamine are widely used stimulant medication. This is the first line. These are the first line drugs used in the management or drug management of the ADHD. The second one, it is non-stimulant medication. This is called atomoxetine. This is for children who have not responded to the stimulant medication. And the other one, we have the alpha agonists like clonidine, guanfacine, hydrochloride. This is mostly it is we have the children who have this ADHD and sleep disorder, and sometimes even when there is hypertension in the children. Common side effects of the stimulant medication include appetite suppression and sleep disturbance. So these are controlled by adjustment of the dose and timing of the medication. There is a lot of studies regarding the management and which are the preferred way of the management. This is the study done, the national treatment profile by the CDC. What type of the treatment do children with ADHD receive? So this is done in the children in the United States, but in the 4 to 17 years old, diagnosed with attention deficit hyperactivity disorder. So the expert recommended using both medication and behavioral therapy for children over 6 years of age. and using behavior therapy as the first line of treatment for children under 6 years of age. Also, CDC researcher found the most common treatment for ADHD is medication, and the majority of children have not received any type of behavioral therapy. So they don't need to receive behavior. Most of them, they want to receive the medication. So on this is we can see that there's different way of the management. For the ADHD, we can see that the medicine is the most commonly wide using management plan for the most of the family using and for the children. And the second, we have the school care, another one, maybe it is less than medicine. So this is a study. They show the prevalence of the parent response ADHD diagnosis and associated treatment among United States children and adolescents. So this is the researcher also found that the children living in the rural area were more likely to have been diagnosed with ADHD and less likely to receive this behavioral treatment in the past year compared with the children living in the urban situation or in the urban area. What other complication of ADHD may be associated with academic unachievement? This is the most important thing. They have problem with the school and the learning, difficulty interpersonal relationship, and poor self-esteem. So these are the main three complications of the ADHD. This is the study. We have the academic and education outcome of children with ADHD. It showed that the attention deficit hyperactivity disorder is associated with the poor grade, poor reading, and math standardized test score, and increased grade retention. How we prevent ADHD? So this is called child rearing practice that include promoting calm environments and opportunities for increasing length of focus on age-appropriate activity may be helpful. This is the first important. The second one is this is too much common now, limiting time spent watching TV, playing rapid response video games also have may be prone because these activities reinforce short attention or short attention span. So now it is commonly using these games, so should be limited, and according to the guidelines of the American Academy of Pediatrics, should be less than 2 hours from the 2 years and above, and less than 2 years should be not used at all. Prevention of the second disabilities can be achieved by education of medical professionals and educators about the signs and symptoms of ADHD and the most appropriate behavior and pharmaceutical intervention. So they should know about the professional should not be know about these symptoms and how you avoid it and what are the medication used. In summary, ADHD affect male more than female. Features include inattention, hyperactivity, and impulsivity. Management include education, psychologist assessment, behavioral programs in school, parenting intervention, medication if necessary. And thank you for listening.
Thank you, dear professor, for your awesome lecture. It was so informative and so exciting. I'm sure that it is really important to share knowledge on these issues, because it is, as you mentioned, it's not completely understood. Again, thanks. If all lecturers are present, unfortunately, we still didn't have Dr. Khalaf with us, but there are some questions in the chat section that may you got them too. I want to share them with the lecturers. Each of you could answer me. I want to be really honored and happy. First of all, I think the first question goes to dear Professor Adnan. Someone asked that, what is your opinion on the relation between MMR vaccine and autism? Dear Professor Adnan. Unfortunately, we didn't have Professor Adnan with us. And also there is two another questions. So we pass it. We have some questions to dear Professor Ibrahim Khasraw. When you prefer to administer fluoxetine to children's breath-holding attack, this drug trigger this problem or the probable anxiety or depression that could increase the rate of BHAs? Dear Professor Ibrahim. Dear Professor Ibrahim, could you hear us?
I think no one.
Yes. Yes.
Thanks a
hello?
lot. Thanks a
hearing
lot,
me?
dear Professor. Yes,
You are
yes,
hearing
your
me?
sound is clear now. Yes.
Actually, the mechanism of action of fluoxetine, it is slow release substance, serotonin inhibitor, which is a neurotransmitter in the brain. It is found that among those children who have a breath holding attack, there is inactivity or there is deficiency of serotonin in their brain. But these are on what I said are not proved to be 100% effective for all children. These are studies that showed that it is useful for such percentage of children with breath holding attack. Perhaps it will be more effective for those who have disturbance in the mood and anxiety or depression in addition to their breath holding attack, because as I said, it may remain up to 8 years old. So, and under 8 years, sometimes, as my colleagues mentioned, that sometimes there is an anxiety, there is depression, and this antidepressant may be effective in such sort of situations.
So nice. And another question that should we give iron to any child with BHA, and how much the dose we should have given?
Yes, it is found that giving iron is routinely helpful as a therapeutic trial, whether the child is deficient in iron or anemic or not. Sometimes we have, as you know, iron has no only role for production of hemoglobin. It has a role in the central nervous system function, in forming neurotransmitters, in forming catecholamines, which has a role. And the dose of it, I think for children, the cheap and effective type of iron is ferrous sulfate. Ferrous sulfate to be given as a therapeutic dose, 6 milligram per kg per day, better to be given for 2 to 3 month period. And to see the result. If it was effective, you can continue, and there is no risk of iron overload among those children.
Many thanks. Thanks a lot. Also, I want to tell all that we have Dr. Jamal Maroof and invited a discussion, a panelist that make us pleased and honored and join us. Dear Dr. Jamal, could you hear us? We will be glad if you join to the panel.
Yes. I am here. I'm honored to be here. Yes.
Many thanks for joining us. And nice to meet you, and thanks for giving us your time. If you help us, I'm gonna ask the questions from you that what is your opinion on the relation between MMR vaccine and autism? If you have any opinion on that.
I think there is no any approval for such connections. Yeah. But I am a bit worried about this question. Is it asked to me or not? I think, yeah, doctor, I think there's some confusion for directing the question.
Okay, thanks a lot. So let's move to the questions about ADHD. I want to be happy any of dear panelists if could help us share their opinion. First of all, I think this is directly goes to Dr. Khalaf, but we don't have Dr. Khalaf with us. So may I ask dear Professor Sasan to answer the question. What is your opinion upon Ritalin mechanism in suppressing aggressiveness in ADHD, the prognosis of ADHD, and is there any relationship between alcoholic father and occurrence of ADHD in his offspring? Dear Professor, you're muted.
Okay, sorry, you heard. So there is also another question I can answer it about. They said that the ADHD can be diagnosed is below 6 years of age. Yes, definitely the ADHD can diagnose it even at 3 years of age. And for diagnosing of that, we have that this rating scale can be used as a questionnaire. And for the rating to as you mentioned, we have the environmental factor, which is multifactorial. It is definitely if the father is alcoholic or not alcoholic, and we have some the father which is have aggressive behavior against their children. So maybe this is the cause, because you have a good environment and we have neglection of their children and leaving their children just to look to the TV or to the any aggressive video games. And sometimes you have the aggressive to their children. This is maybe a cause or a leading cause for the child have to get ADHD.
Many thanks. And also how in ADHD, the level of excitatory neurotransmitters decreased, and they have they make the child become hyperactive. Is it treated with stimulants or not?
So, you know, this is according to the recommendation of American Academy of Pediatrics. So they have the treatment, this management. It is below 6 years of age and above 6 years of age. It is below 6 years of age. It is a behavioral alone. It is behavioral alone, no medication. You should wait. And after 6 years of age, you can start by behavioral, and it is not responding. You should give starting medication. And we have the medication is divided to the 3 groups: the stimulant, non-stimulant, and we have the alpha agonist. If the child responds to the stimulant, it's okay. Not respond, you should go to the non-stimulant. And accordingly, until the child get better. And the child and the family should be strict to the management plan. It is put in by the which is multidisciplinary. There may be psychiatrists, the pediatrician, that is we can give it their management plan to their to the child and to the parent to how we deal. And even in the school, they should have the managing plan.
Many thanks. And as the last question about ADHD, is there any relationship between child's IQ level and presence of ADHD?
Yes, definitely. There is, as mentioned, and we have studies. I mentioned in my talk or my presentation that there is a study that definitely there is affect the education, affect the math, affect the graduation, this academic graduation. Definitely is affect, and we have the memory response of the children. All these are affected by attention deficit hyperactivity disorder.
Many thanks, dear Professor, that with this much busy schedule, you gave us your time. Dear Dr. Jamal Maroof, we will be so happy if you share your point of view with us about behavioral disorders, the topics that we discussed already, autism, ADHD, or anything that you want to mention. Dear Dr. Jamal Maroof, could you hear us? Dear Dr. Jamal.
Yes, doctor. Yes, doctor.
Yes, yes. If you please, if you can share your point of view about this topics, behavioral disorder or anything, we can be with you in some minutes, and we will be so happy if you share your opinion on the topic of the session.
Thank you very much. As we are very new to be familiar with such a subject, it is something growing and still there is no concrete knowledge. But what is newly emerged from United States. It is a new approach to label autistic children as a new form, not a different kind of human being. They are similar to normal children. They have the same brain structure. There is no any concrete or proven brain anomaly by radiological or even by more detailed neurochemical examinations. So many pioneers in the United States, which are working in the field of psychology and behavior, they postulate autism, it is not a matter of behavior. We should not focus to treat their behavior, but we should think about the main or the core abnormality in their brain function. For example, when a parent try to educate or bring up their children, they may not need to have a modern education, or most of the parents from the history till now, they are not obliged to education about teaching their children. It's an intuitive relationship between parent and children. How this relationship become established? Children by themselves, they should have a potential to become like a student under supervision of their parents. But what is the main lack, or what's the main deficit in children with autism? They have not such a potential as a normal children to become a student or to become an apprentice for their supervision or guiding of their parents. So what the parents should do to guide their atypical children like autism? The parents should shift or switch their guiding idea or guiding relationship, how to educate or bring up these type of children. So the main focus or the main therapy toward children with autism, it's better to be treating parents, how to guide their children in another way. And parents should be proud here, not be proud to bringing up a normal child, because bringing up a normal child is a very natural or huge act. It doesn't need more energy. But for parents with children of autism, they should be educated. They should
dear Professor, I'm so sorry for interrupting you. I think there are some speakers on in your room, or maybe there are 2 or 3 microphones are open at the same time, because your voice is not clear and there is a bit echoing.
Yes, I'm sorry for this. I try to. I think I can now talk if you want.
Yes, it's better. It's better.
Okay?
Yes, it's better. Yes.
Yeah.
Continue, please. So sorry.
No, it's okay. This new approach is very up to date in the United States, and still it's not common in the United States, but it's a logical idea. It's a logical idea to work on parents with such a children, not directly working or treating autistic children. Yeah, if you want, can I repeat what I said before?
Sorry.
Let me to say again in a concise way. As we know, relationship between children and parents is something intuitive. Parents does not need to be educated to become a parent. So become a parent for a typical child, not so important mission. But what is important to become a good parent for an autistic child, the parent should have a new approach. Because as I said, a guiding relationship between parent and normal child is intuitive and natural. What does it need? It needs only the potential of the child to become a student or become an apprentice for his parent or for her parent. What is deficit in autistic children is a lack of such a potential to become a student or become apprentice for the guiding of their parents. So parents, they need a new approach to guide their children with autism. It is a comprehensive and detailed protocol, which says we don't need to even connect with the child to treat them. What we need to act and work with the parents. And let us say the strategy is relationship development intervention. We work and we teach the parents to act in another way with their child with autism. Let us say, or concisely, the core deficit in autism is lack of a child to take advantages of the opportunities around them. They cannot have such a potential to take advantage of the surrounding. So they need a new guide or a new parent or a different guide. The visual parenting does not work for children with autism.
Thanks, dear professor.
And every audience here can check up on the www.rdiconnect.com. You can find a lot of information, and even you can find many consultants about such a remediation of autistic children.
Thanks a lot. That information was so useful. We are so pleased to have you with us, and also many thanks to dear Dr. Asufak Saleh for helping us arranging this awesome session. Thanks to all dear lecturers. It was a big honor to have this session with all of you. I hope that we can arrange and plan many programs, workshops, and this kind of seminars in person during a COVID-free New Year. Inshallah, I pass the microphone to Dr. Elmira Memar for.
Thank you very much for inviting me.
Thanks a lot, dear doctor. Thanks a lot.
I myself enjoy a lot and also learn a lot. Thanks, dear lecturers, for sharing your knowledge and also your opinion with us. I should thank to our audiences for their attendance, and also we look forward for future cooperation. Take care of yourself in this pandemic, and bye-bye.
Again, thanks a lot to all lecturers and audiences. Have a good time. We are going to be with you in 15 minutes with the next session, Gender Ambiguity. For getting the certification of attendance, don't forget to register on the website, complete the information, and you can download the certification after finishing the Congress, I think 3 or 4 days later. Take care. Have a good time.
Thank you.